Right. Okay. Sorry. Technical difficulties. So like I said, I'm Kirby Fine with the department. Welcome to the Statewide Children's Committee meeting. Just a few things to go over before we go ahead and get started. A reminder that this meeting is being recorded per Executive Order 71. So it will be posted to the department website within the next day or two. If you're not speaking, please make sure your computer or your phone is muted. Otherwise, we get quite a bit of feedback. Also, if you have any questions or comments, I know we'll be talking about the needs assessment today, so there'll be a lot of discussion. If you could please just state your name so we can have that for the minutes, that would be great. I'm going to go ahead and go through the individuals who have joined via WebEx first, since I can see their name. And then I will go through the individuals who have called in. So like I said, I'm Kirby Fye, I'm with the department. We have Amy Holland, also with the department. Avis Easley with the department. Let me see here. Alicia Smith-Knight. Amy Irvin. I see Elizabeth. Elizabeth, what's your last name?
Hey, Kirby, if that's, I'm guessing I'm the only Elizabeth. It's me, Elizabeth Reed.
I thought so. Hi, Elizabeth.
Hey.
Jerry Moore. Harry Virgo. Lindsay Blevins. Lisa Pellegrin. Megan Gaylord. Melissa Binkley. Melissa McGee. Patrick Luther. Ricky Harris. And Steve Petty. I see three individuals who have called in that I haven't said your name yet. Could you please introduce yourself on the call?
Tammy Summers.
Hi, Tammy.
Hi.
Kim Parker.
Pardon, can you say that again?
Kim Parker.
Oh, hi, Kim.
Hi, Kirby. And this is Melissa Birdwell.
Hi, Melissa. Long time no talk.
Exactly.
All right, Ricky, I'm going to go ahead and hand it over to you.
Thank you so much, Kirby. I want to say welcome, Patrick Luther. I think this is your first meeting. Carrie, do you want to introduce Patrick?
Absolutely. Thank you. I am so excited to get to introduce to this group our new System of Care Initiatives Director, and that is Patrick Luther. So Patrick, if you'd like to say hi to the group, we're so happy you're here.
Good morning. Happy to be here. Looking to learn a lot. Thanks for having me.
Thank you all so much. I'm excited. Glad to know you, Patrick. I am just looking at our needs assessment for 2020. So if you guys don't have that in front of you, it was sent out by Kirby in an email. It's attached, and it's
I could share it, Ricky, if you want.
That'd be awesome. Thank you.
Okay,
so much.
Hold on one second.
And if we can go to page 13, that very last page.
All right, let me.
Oh, this is wonderful. Okay.
We'll just scroll down as we need.
Yes, thank you.
Mm-hmm.
So just a quick refresh on what we submitted in 2020, and boy, did we not know what we did not know, right? These are the items, just as you all know, we do 2 mental health priorities for children's needs and 2 substance abuse priorities. And I think the best course of action for today's discussion, maybe just to start with a quick discussion of how you all kind of see, or whether you do see, that we addressed these needs in our state or not, because the discussion may need to be whether some items need to stay on the list or whether there's new priorities. So starting, I think, with the first one around expanding crisis response and stabilization, you guys want to just chime in on a quick discussion here about any movement forward on that need.
This is Megan Gaylord. I know that the crisis portion of the department is continuing to encourage community-based assessment as much as possible, meaning avoiding emergency rooms. And we know that there's great benefit to assessing children not in an emergency room, but if at all possible, in their school or their home setting that's as natural to them. I don't know this year with the pandemic if this is something we need to include for this year, just because the goal is not to have people congregate in one set location. So I don't know. I don't know if it might. I don't know how the department is counting walk-in centers, but I know if a walk-in center is attached to a psychiatric hospital or a hospital, they're counting it as a hospital location. And the goal is actually to get more than 50% of assessments done outside of an ER setting right now.
That's great. Thank you for sharing that. And
yeah,
go ahead.
Oh, sorry. So this is Lindsay. I wanted to piggyback off of what Megan was saying. This is something I actually brought up in the Region 7 meeting that we had. I feel like it was last week. I don't know what time flies by. We were talking about the needs assessment, and that's exactly what I said too. I mean, I work at Lakeside, and we see a lot of police drop-offs to our location. A lot of times kids are not needing the acute inpatient, psych level of care. And so we're missing a lot, parents aren't coming, or there's, difficulty reaching them. And so it's really hard, and Youth Village is involved in a lot of those assessments. It's really hard to kind of get a full picture of what's going on when you don't have access to everybody. It's made it a little bit easier, I think. And Megan, you can chime in on that. I'm not sure if there's anyone else from Memphis on the call, but with telehealth, I mean, you can somewhat access people a little bit easier, if people have, Zoom capabilities and things like that, or a smartphone versus them having to come in person to get some information. It's a little bit better than, just being via phone, but it's still, a little bit difficult. So I definitely agree that more resources spent in that area would be helpful.
However, I do agree with the need in this for more mobile crisis response staff. If these are outside of an emergency room setting, say they're freestanding, that's a difference between it being an ER. But the goal is that it's a walk-in center, not a drop-off center, as Lindsay indicated. That it's not like, oh, this kid ran away from home, drop them off. But it really needs to be for kids that are truly having a mental health emergency, because the benefit of a walk-in center versus an emergency room is in a walk-in center, you can have comfortable seating, developmentally appropriate toys, developmentally appropriate room. You can have a location should that child actually have to sleep in the walk-in center while awaiting an inpatient bed, and allow a second bed for mom or dad to sleep with them. So there's some benefit to it if it is detached from an emergency room and it's designed to truly be child-centered.
Ricky, this is Carrie Virgo.
I was fixing to say, Carrie.
I have a couple thoughts here. Just putting out there for the group a couple of things that have been going on, partnerships that we have been working on. I'm just going to throw out a bunch of random ideas, and I think this group we can figure out how to move forward with some of it, but I do think we have a few opportunities. We had a training on Friday, so the System of Care office had a training with Monroe Carroll, where we are going to be partnering with them more closely to receive referrals from them for some of those children and youth that are coming into emergency departments that may not necessarily meet criteria for hospitalization, but they're still in need of some kind of intervention. And so one of the things that we are going to do is try to help facilitate some of those referrals as they come in. Laretha Fentress has recently moved over to the department, and she will be doing a lot of referral screening. One of the things we'd like to move forward to in the future is potentially figuring out how to embed a family support specialist into emergency departments. Speaking to what you were talking about, Megan, really having kind of like an alternate area where families can go and have conversation with a family support specialist who may be able to help do some of that triaging of, is this more of a mental health concern or is this really a physical concern, and maybe helping to do some of that warm transfer to actual services with some follow-up to make sure that we're actually closing that gap. Because I think in a lot of different systems we have, whether that is juvenile court or emergency departments, you know, when we walk out, when that family walks out the door, there is this chasm that they have to cross on whether or not they ever even make it to the place they were referred to. And so where do we go? We go back to the emergency room every time there's an issue. And so I think there's a lot of opportunity for us to discuss how we might want to move forward as a state together. In addition to that, I am speaking with the children's director for SAMHSA next week. She wants to talk a little bit more exactly about this, about crisis response and how that fits into a system of care. So just throwing those things out there as potential ideas about how we can move forward with some of these things. Always open to ideas, but I totally agree. Ricky, you went with us a few years ago where we went to New Jersey to look at how their crisis system is set up. And they truly have a phenomenal model of how their crisis system works with getting children and youth services moving forward. And so that could be an opportunity for us to continue to expand on that as well. So whole lot, but there you go.
No, that is great. And I was going to mention our trip to New Jersey too. I think we still have some really great notes and ideas. And I was going to mention also that trip is sort of what prompted our conversation in this committee to change our priority. Crisis for youth has been on our priority list for a long time in the Children's Committee, but we changed the language, I think last year, sometime after the trip to New Jersey, to crisis response and stabilization, instead of saying we wanted crisis stabilization units. So to that end, yes, I think there's lots we can still gather from what we learned in New Jersey and apply here. The other thing I was going to mention, I read, just thinking about this meeting a couple of days ago, I read a CDC report that came out since March of 2020. It stated that mental health visits, children's mental health visits to the ER were up 31% for children 12 and over, and up 24% for 11 and under. So to I don't know if it was Lindsay or Megan's comments about the ER visits, and then to Carrie's comments about the ED triage needs, I think we're right in the place we need to be in addressing this need for children. And so I think at this point, then our question as a committee is, do we want to keep this priority in place? And if yes, then do we need to change any language that's currently written in this priority?
I'm definitely going to jump on the bandwagon of let's keep this, because I would love to see if we can't move this forward. I think we can do a whole lot better job, and now Crisis has a new director, Jennifer Armstrong. And so she'll be coming in with lots of fresh ideas from the field. I mean, she was at, I believe it was Centerstone. And so I think this is one that I feel like pretty strongly we need to keep, and we'll support however we need to.
For
I
that.
will second that. Our membership would definitely support this staying a number one priority.
Alicia,
Yes.
are you all comfortable with the language that's in the current priority?
Now that I need to look at more.
Well, I could definitely send that out to the committee after again and just make sure everybody has a chance to kind of review language and provide any feedback. But from the others on the call, sounds like we've got several interested in continuing this priority. Is everybody feeling good about that, or do we have any concerns before we move on? I'll take silence as acceptance. Let's then look at our next one. And Melissa Binkley, I hope you are still on the call because I know that you'll have some thoughts about this. Our next priority was to increase and establish preschool and school age mental health screenings and services to ensure prevention and early intervention for young children. So discussion and input on what progress we've made on this priority.
So, hi Ricky, how are you? Can y'all hear me?
It's muted, sorry, I'm good.
Oh, good. So a couple of things. One, we're included now in the 3-year plan, as well as the annual review for TDMHSAS with the RIP program and child care consultation, both in those places. So there's some representation of services for children in that age range. I think, one, I'm really glad to see this goal on here. So thank you, those of you that were advocating for it in the early days. I guess one of my questions might be about the match between the need and the data, because the need talks about preschool and school aged, but the data references 0 to 8. And so I wonder about us being a little bit more particular with our language in the need and being able to identify that infant toddler all the way up through age 8 in the need for screenings and services, particularly with the prevention component, promotion and prevention, even with those early ages.
Thank you. If you have any suggestions, and you can shoot me an email later on some language changes, I'm glad to hear it. Okay. Other thoughts? I know in discussions last year about this priority, we were all very much on the same page about this priority being our second priority, and there was lots of support around this. So I think now if we are at the place of deciding, do we want to keep this one on the list, or do we need to discuss other ideas? What do you guys think?
Hey, Ricky, it's Lindsay. I do wonder, I mean, I know Melissa said that we've made some progress and it's now on, the 3-year plan and there's some representation, but I mean, like you mentioned at the beginning, no one knew kind of what 2020 was going to bring us. And I do wonder how much we've missed with a lot of these kids just staying at home at this point. So I definitely think that there is probably some trauma that's happened. I mean, there's a lot of stuff that I think has been going on this past year that I definitely think it's going to be important for us to make sure that, coming into this year and probably into 2022, that we've got a major focus on our young kids and how some of this has impacted them, and doing some prevention work before it gets to, before they get older. So, I mean, I agree that we probably need to look at our verbiage and what we're saying and the need to make sure that we're including the younger kids as well.
Mm-hmm.
Yeah, I like the idea of younger kids. I also, this is Megan Gaylord, by the way. I also like looking at partnerships. So when we look at how children are identified for mental health needs, once they hit school age, we identify maybe if they had like early intervention, they might be identified, maybe if they went to their pediatrician. And I think one of the big things we're missing, I think, is coordination between like Department of Health and us to really push out information on the Columbia Suicide Severity Rating Scale or maybe certain depression indicators to get them into the hands of pediatricians. So in some cases, a family is going to be more open about what's going on with their child and their family with their child's pediatrician than they are a teacher or a school counselor, to be able to identify them. I mean, we've had situations where when a pediatrician has adopted using the Columbia Suicide Severity Rating Scale. I had a case last night. Because that pediatrician did that instrument with that child at a well child visit, that child disclosed ideations and was able to get mental health help. Whereas if that pediatrician had not asked any questions about mental health well-being as part of a well child visit, it would have been completely missed. So I wonder if we could look at a mental health priority, maybe in place of the walk-in centers to really look at a partnership with Department of Health to provide training, education, documentation, flyers, handouts to the mental health community, because to the medical community, specifically pediatricians, and maybe those that do pediatric specialization. I wonder if that would be something that would have a really great impact on child mental health, to include crisis stabilization, access to services, and also help some with early identification with the kiddos that we're looking at under 8, or early childhood.
Megan, what's the, I'm not so familiar with that scale. Do you know what that's age rated to?
There are 2 versions. There's one that can be used ages 7 and up, 8 and up, and then there's a caregiver version that you can do by asking the family. And so that's there's one that's the pediatric or cognitively impaired. So if you also have a child with cognitive impairment that wouldn't be able to answer the 6 questions themselves, that it could be used that you would ask the questions of the parent. And it's really easy to administer. It takes 5 minutes or less. And there's pretty easy training. I mean, because we have the Lighthouse, the Columbia Lighthouse Clearinghouse that does the training for free. But I think it would take multiple years to get that information into the hands of the pediatrician, and then to give them information about crisis services in their area. So instead of just sending their child over to the emergency room, did you know you can call and have this assessment done in your office? Did you know we can make arrangements to do it in a more childlike setting? And so I wonder if that would actually hit a lot of the goals that both the department and our mental health providers have. Because we would love to identify a kid that's at the beginning stages of depression instead of a kid that is so far off that they've had an attempt. And I really wonder what partnership we can build with the medical community through some specific stuff on the needs assessment to make that happen.
I know there's been a fair amount of work with TNAP and Blue Care and behavioral health providers on this particular item. Can't remember how long ago this started. Maybe, it may have been 5-6 years ago, where they're, trying to embed more and more behavioral health screenings in pediatric offices, including things like the Columbia scale and others. So I know that there's been quite a bit of work, and I don't really know where that lies today. Does anybody know what's happening today with that?
So, Alicia, I don't know if I'm speaking to the same project that you're speaking to, but there was a 0 to 3 grant. Is that the one you're talking about?
No,
About
this was that one.
Okay.
This was the BHIP. It was a partnership with TNAP and Blue Cross to really look at embedding screenings in pediatric offices. Let me go on my computer and see if I can get more information. Send a link.
Yeah, this is Lindsay. I haven't heard anything about that in the last several years. I know I've gone to some trainings that Blue Care was providing years ago in the area, specifically targeting the doctors, like you're mentioning, but I haven't heard of any initiatives more recently. So I'd be encouraged and definitely would love to be able to share some of that, because the doctors that I sat through some of the trainings with were very much appreciative and wanting to use the information.
Mm-hmm. Hi, it's Lisa Pellegrin. You all talking about VHIP and where the EPSD&T is performed. Is that right? Are kids in state custody? I can tell you that our new Deputy Commissioner of Child Health, Dr. Lowen, has taken an interest in a move toward kids seeing like more of a primary care physician for EPSD&T. However, that's still in the early stages. But if there's a little bit of buzz about it, that could potentially be the source of it. So certainly she'll be working on that and communicating with appropriate stakeholders as she proceeds in that direction.
I think too, there may be some room here to, discuss with Aim High what they have put in place to support some of these infant and toddler ages in that younger range. Right now, they're mostly focused on under 3. And so there's some space to involve them in helping us identify what kind of prevention and intervention deficits there are across the state. I know they've recently done a big survey of community needs. Obviously, COVID has turned all of that on its head, but a good kind of starting point for us to see what's missing, what's available, where we could support. And I think pediatricians' offices and OBGYN for the perinatal and prenatal mental health was a place to start for them as well. So thinking about the healthcare field is important, I think, in the pediatric side, but also that idea of perinatal and prenatal mental health is something to consider about how we set a foundation for the youngest in this age group.
Yeah. I love that idea, Melissa. This is Megan. One of the things looking at perinatal care is also like sharing information about the Edinburgh, which is a self-administered instrument that can be used to measure depression, but also ACEs information. Imagine if we had a pregnant mom, maybe in her second trimester, fill out her own ACEs survey, and that OBGYN refers her to her own services to then help prevent ACEs in her own child. Or, at the first pediatrician visit, they double check and say, hey, let me go over your ACE stuff. And then that way we can get that infant referred with, maybe they need a mother-baby program that they can invest in. So I love that idea of including perinatal care.
Well, this sounds great. If I'm following the discussion right, then it sounds like it's an area we still need to focus on. It still needs some work, but there's groups that are making some progress. My thought is to propose we leave it here as a priority and really focus on our outreach to the pediatric and medical communities. And Kirby, or whoever's taking notes, as a side note, is a future guest to invite to our committee would maybe be someone from TNAP to see what their outreach is with pediatricians across the state. So what do you guys think about leaving this one on the list and maybe tweaking our language just a bit to try and improve our partnerships with the medical community? I'm getting some thumbs up.
I like it. And in addition to having TNAP at a meeting, we might want to have either someone, Melissa was talking about that 0 to 3 planning grant that has continued on with a partnership with Aim High and TennCare to look at financing infant mental health services through Medicaid. We're still in that process. It might be nice in the next month or so to just get an update on how that's going and where we are with that.
That's great. Yes. Okay. Any opposition to leaving that one in place as a priority before we move forward? Okay. We'll move on to the substance abuse priorities, but I wanted to mention something before we do, just because you all are part of this group and have networks across, the state to make sure we're getting the word out about mental health services for children. I have heard over and over, and I recently heard it on the news a couple of nights ago, this idea that there aren't a lot of resources for children and families struggling because of COVID, which is not exactly true. And Carrie, I talked with Matthew Perriott yesterday about this, and we were actually able to get on and correct one story in particular that a news station had stated they went onto the Department of Mental Health website to find some COVID relief counseling services, particularly for children, and they weren't able to find anything. And of course, I'm yelling at the TV like, no, there's so many places they can go.
Thanks for that advocacy, Ricky.
Yes. So we actually called Fox 17 and we got on there yesterday and talked about all the avenues. And shared with Fox 17 reporters about the avenues. I mean, that we know of. Obviously, Centerstone has some free counseling resources for COVID relief. I know that Helen Ross McNabb has a mobile health clinic for rural areas. Tennessee Voices has free counseling. So we know there are lots of areas. I would just encourage you all as invested members of this committee and children's mental health issues to just continue to put the word out on all the resources, because families don't know where to look for these, for this information. So keep spreading the word if you can. So with that, let's look at substance abuse. Our first priority under the substance abuse category was to increase access to home-based substance abuse services for mothers with young children. What do you guys think in terms of progress made, and where are we in terms of needing to move to a new priority or leave this one here?
So, Lisa may be able to speak to this. Well, I'm sure Lisa can speak to this better than I can, but the expansion of home-based services is statewide now through Department of Health. So there may be some opportunities for us to talk about how this has changed, what's more available to families, those kinds of things.
Lindsay, correct me if I'm wrong. If you recall, there was someone on the committee who was really seeing this as a huge barrier for mothers that was advocating for this. And I don't recall who it was. Do you recall?
No, I was just thinking the same thing. I cannot remember who had said that last year.
Okay.
But it is, I don't know what this is Megan. I don't know what the improvement is, but it is a huge issue. Especially now that, even if you had a situation where you could bring your young child with you or an infant with you to session, a lot of people with infants and young children are not getting out right now due to COVID. Mm-hmm. And then the transportation issue is because Medicaid transportation will only allow the mother to go, not the children. No accompanied children can go. And so if you have transportation restrictions or you live in a rural area, I think it's really good. And I think talking about not just, I think, really talking about the in-home visitor as well as the telehealth services, I think can be really good for supporting sobriety. I think it would still be a priority, but I don't have any data to indicate any shift over the last year.
Could the executive orders that expanded the use of telehealth have affected this in a positive way? We don't do substance abuse services, so I'm not exactly sure what that looks like now.
Yes and no. Part of the problem that and anyone who works in addictions that's on here can talk about it. The increase in addiction and addiction-related death has been problematic, just because we've had these stimulus payments that have come out, which provide someone who is struggling with addiction with a whole lot of portable income to fuel their addiction. So I know use has risen. I don't know what utilization of telehealth for those that are struggling. I know it's been easier, but if we were working this into like the 3-year plan, eventually those telehealth allowances are going to go away, and that providers aren't going to be able to bill for a telehealth session due to Medicaid restrictions.
Alicia, have you heard anything from providers on this?
Yeah, I'm thinking about that now and trying to think about what I know. I know that telehealth has absolutely increased the provision of addiction services to adults.
Mm-hmm.
I know that there have been maybe a couple more IOP, definitely lots of IOP groups for adults. I don't know that I have that information for children and youth, and definitely I don't have the information for mothers with young children. So I would need to really get back, maybe put this on our CNY agenda to discuss in the next couple of weeks.
That's what I was thinking. Maybe if you didn't mind putting it on that agenda and doing a little bit of information gathering before we decide what needs to happen on this one. Megan,
Yeah,
did
I'd be
you
happy to do that. I think we meet in 2 weeks. I'll definitely do that.
Thank you.
I can actually speak to meet number 2 under substance abuse in a little bit. So one of the things we did here, these villages did, was at the beginning of the pandemic, I guess not at the very beginning, it was like early summer. We really noticed that kids were really going to be struggling over the summer with no social activities, all of these camps canceling. So we actually reached out to each of our site directors with Health Connect to say, hey, what can we do to increase daytime services? And in response, they actually increased some of their IOP efforts and actually created an additional IOP group. So I know at least in our region, that actually enhanced. A lot of that was being done over telehealth. And so a lot of that, those IOPs for the most part were specifically substance use. We're seeing mixed effectiveness, and I think maybe pulling in maybe for someone from Health Connect or from some of the other larger providers that provide substance abuse IOP. It's really hard to get a kid to sit still for 9 hours in front of a computer for telehealth. And so I don't know if going past pandemic, maybe if we look at maybe if we suggest looking at an IOP model that would include maybe something like kind of IOP light mixed with CCFT. So where maybe you attended the IOP group 2 days a week, and then you had another in-home visit to provide a lot more direct work with your parent in your home environment. So I don't know if maybe proposing maybe like starting like a hybrid IOP model for rural kids. Because what we find is that if we have parents that work second shift or it's hard to get that kid to attend the entire 9-hour IOP during the week. Virtually. It's a lot easier when they're in person and their activities and you can move around a little bit and pull them out for individual or pull them out for family. It's a little bit harder, we're finding, online to keep them engaged.
Yeah, I was gonna just echo that. I know for our providers, for adults, and I would imagine this would be for kids as well, the IOP times have been greatly shortened, and a lot of providers have been doing a hybrid of, some in person and some, telehealth. But yeah, nobody's been sitting for that full time with our providers.
Mm-hmm.
And so I wonder if it needs to be like coordinating, because the majority of the people attending IOP are on some form of Medicaid cover kids. There are occasionally people that have private insurance that are in IOP, but to maybe indicate that this is a need, but there's a need for it to be more of a hybrid model, especially since that parent isn't necessarily transporting them to and from the IOP. To increase the family involvement, specifically in our rural areas. So maybe I allow for the creation of a billing item for Medicaid, or the allowance for creation of hybrid programs. I wonder if that would be more effective for a lot of our kids in the rural area, where it's like I said, like a hybrid, where it's like maybe 2 days you go to the group, and then the third visit is done with an additional staff member doing that, more in an individual or doing family work during that time.
Okay, so this is Lindsay. I have a couple comments on what Megan's saying. So I definitely think that with the pandemic, we have expanded telehealth in this area, or specifically people's willingness to participate in telehealth. I mean, I think that there was a lot of uncomfortableness around it, and we've really been thrust into people really having to adjust and learn to use technology in different ways. And I think that has, like Megan's talked about, capitalizing some of the more rural areas where people did have difficulties accessing treatment or telehealth wasn't an option. It's an option now. I definitely think that there are some drawbacks, obviously, if you're, via video versus in person. So I like the idea, like Megan's talking about, you really do have to include the family. So a lot of our IOP services, when it comes to adolescents, there is a family component. And so we ensure that when they're in IOP, that we're also doing family sessions with them every week. So we're communicating with them and making sure that they're understanding the skills that are being taught to the adolescent so they can work on those in the home as well. But it has been really successful to be able to interact with the family for sure. Now, there are kids with Medicaid, yes. We also have commercially insured kids who are in the program as well. And that's available really to anybody who's in the state, but most of our kids are located more in the Memphis area and then potentially in the rural West area as well. The other thing that I wanted to say when we're talking about the first need for substance abuse and looking at moms with young children, I wonder if we also need to include some notes about peer support, because, there are potentially options for, IOP or things like that for mothers who are needing substance abuse services, potentially transportation or, childcare are issues. But, we've had some people, like we have peer support specialists who work here on our campus, and we've had some that also work for nonprofits that do peer support. So they are pre-COVID, going into people's houses, meeting with them, providing that support and encouragement as a supplement to the IOP services or whatever other services that the mom or the patient is receiving. And they have found some success in that. And I know over the course of the past few years, we've worked really hard about being able to bill for some peer support. I'm not sure exactly where all the insurance companies are with billing for peer support, but I definitely think maybe including something of that nature, if we're keeping that similar goal, might be helpful.
Thank you, Lindsay. That is helpful. Is there anything from anyone on the call, is there anything that we might be missing in the substance abuse area for children that we need to discuss?
So this is Megan. The only other thing I can think of is a lot of our pediatric addictions treatment focuses on, I don't want to call them the lighter drugs, but things like marijuana, alcohol. But we are seeing an increase in child methamphetamine use.
Oh, goodness.
Specifically, over, I'd say, the last year, an increase in methamphetamine use. And so some of our addictions programs shy away from things that are more than like a one-time use of cocaine or, one-time use of methamphetamine. So I don't know if, maybe not for this year, but longitudinally, we need to maybe look at helping to establish either treatment protocols for pediatrics using methamphetamine or identify, because usually you're not going to successfully treat methamphetamine addiction typically on an outpatient basis, but maybe looking at the increase of RTC programs that are able to effectively treat something other than marijuana, occasional prescription pill use, and alcohol.
Thank you for that. Any other things that we need to consider?
I was trying to see if the department's data team is on the call and whether or not this would be trends that we might be seeing in 10-wits. And if we could, I don't know, access this information, like the, kind of the increase in, these more troubling substances. I'm looking, I don't see the folks I'm normally.
We're also seeing fewer options for children who have true dual diagnosis that have a lot of comorbid, either suicidal, homicidal, aggression, runaway, in addition to pretty significant substance use. A lot of our existing RTC programs are saying, oh no, that child is too severe for our program. But then we can't find a program that can accept that child. And in some cases, that means that child has delinquent charges and ends up in our state or child welfare system to get the help they need versus not having the ability to get it as a private citizen non-custodially. So I think establishing RTCs or having RTCs that might be open to forming programs, A, to keep those kids in state, and B, to actually meet the more severe addiction need with true dual diagnosis might be a need.
That makes sense.
Hi, this is Avis. And I heard Alicia mention there's no one on the call from the data or the research team right now that can respond to your question or needing information from teen with substance abuse, but there's certainly something that we can reach out to the substance abuse team or research person on that team to get some additional information that may be helpful to the group on that.
Thank you, Avis.
Mm-hmm.
So we're getting near the end of our meeting, and I just want to recap the substance abuse priority discussion. It sounds like both of the priorities that are currently listed are still things we need to work on, but there's some things that need to be tweaked it sounds like in both categories, and maybe a little more data needed in order to build our little data section in the priority needs assessment. So is everyone okay with Lindsay and me taking this discussion back and tweaking the language a little bit, looking at data and getting this resent out for you all's approval?
I think that sounds great, Ricky.
Thank you, Carrie.
And make sure, I don't know if you all saw it, Ricky, in the comments, there was a couple things in there that you guys may want to use in your notes too.
Oh, great. Okay.
In particular, Steve Petty brought up putting some language in about peer support in these, maybe a little more heavily. And I mean, you know me, I'm gonna always jump on that wagon. So
love it. Okay. Sounds good. You guys, thank you so much for the discussion. I can't tell you how much I enjoy these conversations in this committee, and love being able to hear from you all on what your thoughts are. So until we meet again, unless there's any other things we need to talk about, I guess we'll reconvene next time we meet. Avis, I did want to ask you something. What is our timeline on completing our needs assessment?
Hey, Ricky, it's April 15th.
Oh, perfect. Thank you, Kirby.
Sorry, I was trying to respond and I was on mute. I was gonna say it's usually April 1st, but we extended to April 15th this year. So
okay, great. Well, we have good time to get this work done and get this back out to you guys for a little more discussion at our next meeting. So thank you guys for being on the call today, and I look forward to talking to you all and hopefully seeing you all sometime soon.
thanks everybody.
Bye.
Thanks, Ricky. Bye.
Bye.